and Grand Rounds, our Roy Benke Grand Rounds. Pleasure to have Dr. David Ying here from our Division of Rheumatology out of the shop of Dr. Sakari and Dr. Young out of the VA. So Dr. Ying is a graduate of MIT. Then he went to Washington University in St. Louis, followed by his medical school at the University of, his residency. After graduating from medical school from WashU, David went to the University of Miami, where ironically he worked with Dr. Larry Young. Larry was on staff at the University of Miami in rheumatology, so sort of a foreshadowing of the future here. Following graduation from he went to California, since he hadn't checked off that state yet, and trained at UCSF, one of the premier institutions for rheumatology training. And he did a rheumatology fellowship that included a research year. So David did 3 years of rheumatology training. He stayed in private practice in the California area before deciding to come back to a state he'd already checked off in Florida, and joined us in 2022 in our Division of Rheumatology. Was recruited here by Dr. Young. And as I mentioned before, they had worked together at Miami, so it was a really great fit. We're very excited about our Division of Rheumatology, which has recruited a lot of great young folks. And now, as I mentioned, is currently led by Interim Division Director and new Program Director, Dr. Sakari. And David is going to give us a great talk today about a very important topic, which is atherosclerotic risk in rheumatic diseases. Thank you, David. David, who is very well liked by our residents and our fellows for his great teaching. He'll get to show off this in our grand rounds today. So David, take it away. Thank you very much.
That works. Thank you, Dr. Lama. All right. So as Dr. Lama said, I'm going to be talking about atherosclerotic risk in rheumatic diseases. And we'll start.
You have your mic off, Dr. Ying.
Oh, sorry. Sorry about that.
No problem.
There you go. Now you got it. Now you got it going on there. So
Okay.
We can see your slides very nicely.
Okay. All right. Sorry. All right. Thank you, Dr. Zaman, for the introduction. I'm going to be talking about atherosclerotic risk in rheumatic diseases, which was one of the topics that I did some research in. But I'll start off with a brief case. This was a real patient that I saw on my first week of rheumatology electives as a third-year medical student at Barnes Jewish Hospital. Although the EKG on this slide is not her actual EKG, because I obviously do not have access to her medical records now. So it's more of a representative case, but it was a real patient. Yeah, so I was on the rheumatology consult service, and we were called for a young female in her 20s who presented to the ED with typical chest pain. She had an established diagnosis of lupus, followed by one of the faculty in clinic, but was otherwise fairly healthy without any known cardiac history. So as you can see on this, the nice arrows on this EKG, she has some multiple ST depressions. And long story short, she was diagnosed with an NSTEMI at the ripe young age of 25. So these are the objectives we'll try to cover today. We're going to talk about the pathogenesis of accelerated atherosclerosis in rheumatic disease, focusing on RA and lupus, where there's the most data. Also talk about the relative risk of cardiovascular disease among the different rheumatic diseases, talk about disease-specific risk factors for cardiovascular disease in RA and lupus, patient-specific risk, and then I'll look into how we can estimate this risk in our patients with RA, and then finally some clinical implications for management of these patients in clinic in terms of their cardiovascular risk. So why do rheumatologists care about atherosclerosis? Well, it all comes down to mortality, as it always should with evidence-based medicine. As far back as the 1950s, researchers were noting that patients with RA had excess mortality compared to the general population. And that mortality is at least partly due to cardiovascular mortality. There's accumulated evidence that this mortality is due to atherosclerotic disease, which is the major contributor to cardiovascular mortality in general population. This fairly recent meta-analysis of 24 observational studies in RA showed about a 59% increased rate of cardiovascular mortality in RA compared to the general population. There's a similar pattern in lupus for both overall mortality and cardiovascular events, although there's not nearly as much data for lupus compared to RA, mostly due to the different prevalences. So to understand why, we need to go back to our immunology textbooks for a moment. In the past, atherosclerosis was thought to be a passive process of lipid accumulation in the vessel wall, but we now know that atherosclerosis is an inflammatory process. So macrophages take up oxidized LDL in the subendothelial space, and they release a lot of pro-inflammatory molecules like IL-1, IL-6, and TNF-alpha. These three are also all co-stimulating molecules that are targeted by our biological medications that we use to treat various rheumatic diseases. And one of these, canakinumab, is an IL-1 inhibitor, was in the news back in 2017. There's an RCT that showed a lower cardiovascular event rate in patients, in non-rheumatic disease patients who were given this medication compared to placebo. So there has been some studies looking at this in the general population as well, although obviously that did not proceed to market. Another cytokine, IL-6, which we had talked about earlier, triggers the liver to make CRP, which, as we all know, is elevated in many of our rheumatic diseases. CRP is known to be an independent predictor of atherosclerotic disease in the general population. And separately, lymphocytes, including primarily Th1 cells, have been found to accumulate in atherosclerotic plaques. And these cells produce pro-inflammatory cytokines like interferon gamma and TNF-alpha. So there's another mechanistic pathway between inflammation and atherosclerosis, and that's via hypoglycemia. In both RA and lupus, higher inflammatory markers have been found to correlate with increased insulin resistance. The prevalence of metabolic syndrome appears to be higher in RA patients compared to controls as well. So this all suggests that rheumatic diseases may have a similarly increased atherosclerotic risk as compared to the well-established risk that we know about with diabetes.
No.
Grand round.
So take a slight detour away from RA and lupus to the world of the more rare rheumatic diseases. Well, we'll look briefly at systemic sclerosis, also known as scleroderma. So more than any other of our diseases besides the vasculitides, vasculopathy plays a large role in the pathogenesis of scleroderma. This is primarily reflected in the microvascular disease, which contributes to the classic features of Raynaud's phenomenon in distal extremities, as well as pulmonary arterial hypertension in the pulmonary vasculature. But like we saw earlier with RA and lupus, there's increasingly thought to be macrovascular damage as well, probably caused by the same endothelial dysfunction that results in the microvascular disease. So let's go back to the clinical data, which there's a lot more for RA and to a lesser extent lupus. So we saw the cardiovascular mortality earlier, but what about cardiovascular events? So this is generally defined as MI, stroke, and peripheral arterial disease. So large vessel disease. And it turns out that for RA, according to this meta-analysis, the relative risk is 55% higher, which is not all that different from the mortality risk we saw of 59% earlier. In the same meta-analysis for lupus, the relative risk was a little bit higher, around twofold, but there was a much wider confidence interval. So there's much less data for scleroderma, but the same pattern seems to hold in this different meta-analysis. There's an increased risk of cardiovascular disease as a whole, as well as MI and stroke separately, with hazard ratios around 1.5 to 2.5. Now, this study also looked at peripheral vascular disease, and the risk seems much higher, but this is all from administrative data. So given the limitations of that, diagnoses of peripheral vascular disease have to be taken with a grain of salt in scleroderma patients because it's very easy to confuse microvascular disease with the macrovascular peripheral vascular disease, which is the main um, relevant point we're looking at atherosclerosis. So these findings raise the question of whether atherosclerotic events are occurring more often because our patients have a higher rate of traditional atherosclerotic risk factors. So the same factors that we use when we calculate a Framingham risk score. So the question is, are rheumatic disease patients getting cardiovascular events because they're sicker at baseline, or can we attribute it more to their rheumatic disease? Now, most, if not all, the studies that we saw earlier in the meta-analysis data attempt to control for these comorbidities by matching controls with similar comorbidities. So to some extent, these factors are already taken into account, but adjustments aren't perfect. So the prevalence about the question about risk factor prevalence is interesting in its own regard as well. So here we're looking at studies that compare the prevalence of various atherosclerotic risk factors in RA patients compared to age and sex matched controls. Obviously, there's a caveat that disease and treatment factors can skew this data. So according to this meta-analysis of the four main non-demographic risk factors, which are smoking, hypertension, diabetes, and hyperlipidemia, there seems to only be some signal for increased prevalence of smoking and diabetes in RA. Now, this kind of makes sense. So smoking is a well-known risk factor for RA itself. So the increased prevalence of smoking in RA is not a big surprise. And this increased rate of smoking probably does contribute to some of the increased atherosclerotic risk in RA. The data for diabetes is trickier to interpret because obviously we use a lot of steroids in RA. Less so now than in the past. And we all know that steroids raise your risk of diabetes. So it's possible this increased prevalence of diabetes is more of a treatment effect. More importantly, hyperlipidemia does not appear to be more common in RA, according to this study. So a little bit more about that. So the lipid story in RA is pretty interesting because it's been observed that in RA patients, lower serum cholesterol is associated with higher cardiovascular risk. This is probably because lipid levels decrease in the setting of systemic inflammation. And this phenomenon is not unique to rheumatic diseases, but has been found in many other settings of high inflammation. And this effect seems to disappear once the inflammatory state resolves. So in summary, lipid levels definitely matter, but high cholesterol is clearly not the main reason RA patients are getting atherosclerosis. So there's some data on lupus. There's not as much data in lupus patients. The best data I could find was about 200 patients where they matched by demographics, but also by hypertension status. So obviously hypertension can't be compared here. But in lupus, the other risk factors don't look all that different between lupus patients and controls. So what are some disease-specific risk factors for atherosclerotic disease in RA and lupus? So in RA, atherosclerotic disease does tend to correlate with longer duration of disease. So the risk of MI was significantly higher in women with RA for more than 10 years compared to less than 10 years. And looking at coronary artery calcification is much more common in well-established RA compared to early RA. Now, for lupus, on the contrary, there's some data that the risk of cardiovascular disease, especially MI, is highest very early in the disease course, even prior to lupus diagnosis. Now, normally, we wouldn't attribute pre-existing cardiovascular events to someone who's diagnosed with lupus, but given how difficult it is to diagnose lupus and the fact that the autoantibodies will often exist years before the diagnosis of lupus, we'll sort of accept that to a certain extent. And difference with RA may also be in that lupus patients are often diagnosed with their disease at a time when they're having acute organ-threatening disease like lupus nephritis, which can contribute their own cardiovascular risk on its own. So as expected, given the role of inflammation in atherosclerotic disease, persistent disease activity in RA and lupus are associated with atherosclerotic events. So in one RA study, the population attributable risk of cardiovascular disease for one of our disease activity scores, DAS28, was comparable to that for total cholesterol. And in another RA study, the incidence of MI was significantly lower in patients that responded to a TNF inhibitor as compared to non-responders to TNF inhibitors. And for lupus, cardiovascular events have been associated with increased disease activity, higher double-stranded DNA levels, low complement levels, and the presence of lupus anticoagulant. Going on to medications, so some of the medications that we use to treat rheumatic disease are probably contribute to atherosclerotic risks. And the biggest one is glucocorticoids, which are associated with a higher risk of cardiovascular events in both RA and lupus, primarily at doses greater than 5 milligrams of prednisone per day. Now, this is at least partly due to the worsening of other traditional risk factors such as cholesterol, diabetes, and obesity from the steroids rather than perhaps any specific effect of steroids, but obviously those are important as well. Now, for the steroids, it's hard to associate the effect of steroids from disease activity because we generally only give steroids in someone who's more active. So it does become a chicken or the egg problem, but that association is definitely there, and it's a strong association. NSAIDs are another common class of medications we use by RA patients, and those obviously have their own well-known cardiovascular risks. But more importantly, the vast majority of the medications we use, the DMARDs, these modifying rheumatic drugs like methotrexate, leflunomide, and have not been associated with their own cardiovascular risk. There's two perhaps exceptions. So there's two classes of neoagents used for RA, IL-6 inhibitors and JAK inhibitors are known to increase serum cholesterol as a side effect. But this effect has not been shown to directly correlate to a higher cardiovascular risk. So it's always something we check in these patients before starting these patients on IL-6 or JAK inhibitors, which always check their cholesterol. And sometimes we see them go up after starting, but it's not clear how clinically relevant that increase is. Because as I saw earlier, there is a association between disease activity and systemic inflammation and in cholesterol levels. That seems to be most readily seen in patients that start drugs that target IL-6. And then one of the JAK inhibitors, tofacitinib, does have an FDA black box warning for major cardiovascular events after post-marketing studies. But this is probably due to an increased risk of thrombosis rather than true atherosclerosis. So that brings us to the question of whether traditional risk calculators are accurate in our patients with rheumatic disease. There's not really enough data in lupus or the disease, so I'll only be talking about RA here. And the studies have shown that general population risk estimators underestimate cardiovascular risk in RA. There have been efforts to develop cardiovascular risk estimators that are more accurate in RA patients, but none have been shown to be more accurate than the general population risk estimators when they've been looked at in external validation studies. There is one calculator called Q-Risk that's used in the UK that includes RA status among the inputs, but it was found to overestimate the cardiovascular risk in an RA cohort. And other attempts at risk estimation include there's an expert opinion by the EULAR, which is the main European Rheumatology Association, that recommends using a multiplier of 1.5 in patients with RA. But this was also later shown to not improve risk stratification above the general population risk calculator. So in short, the current recommendations are to still use the general population risk calculators in patients with RA, with a caveat that the true risk is probably higher than what you'll get. But this is still an avenue of active research. So what can we do with this information when we're seeing these patients in our clinics? So the first step in cardiovascular prevention, as we all know, is lifestyle modification. That's not really that different in our patients. But there's obviously more than the three lifestyle modifications that are listed on the slide, but there are some special considerations for smoking, exercise, and hypertension in our patients. So as I mentioned before, smoking is a risk factor for development of RA itself, but also for increased RA disease activity and RA-associated lung disease. So beyond the cardiovascular benefits of smoking cessation, there are some additional RA-specific benefits of smoking cessation. Standardized exercise programs may be difficult for our patients with active joint disease or chronic joint deformities, so they may benefit from modified activity programs such as less intense or non-weight-bearing exercises. Hypertension, as we saw earlier, is not necessarily more common in RA and lupus, but a few of our medications may worsen hypertension, especially NSAIDs, steroids, and leflunomide. Oops. And so speaking of NSAIDs and steroids, another important aspect of cardiovascular prevention is minimizing those two medications because of their well-known effects on the cardiovascular system. So, on the other hand, we know that we still need to control disease activity to prevent systemic inflammation that also contributes to atherosclerosis. So this is a delicate balance. So early initiation of our immunosuppressive agents and tapering glucocorticoids as fast as appropriate are the two important interventions that we as rheumatologists can do in this regard. In terms of the direct effect of our DMARDs on cardiovascular disease, beyond their effect on controlling disease activity, hydroxychloroquine, which we use in multiple conditions, including RA and lupus, does seem to have several benefits on cardiovascular disease itself. It's known to have a mild hypoglycemic effect, so it may reduce the risk of diabetes, and it also appears to reduce the risk of thrombosis in lupus and APLS. And there's some evidence that it also reduces total cholesterol. So, it's a very good drug in general. It's quite safe. And obviously, there might be some benefits outside of the RA effect or the effect on the RA or lupus. And finally, statins should be used to lower cholesterol if otherwise indicated, and after the trial of lifestyle modification, as is in the general population. And another caveat to this is that, as we talked about earlier, cholesterol levels are inversely correlated with inflammation. So if you check a patient's cholesterol and it's normal when their RA is very active, it probably makes sense to repeat that after their disease is better controlled to get a more accurate reading because it may be falsely low in that setting. So in terms of using statins to reduce atherosclerotic risk in RA, there's been at least one large RCT that looked at using it in RA patients without known atherosclerotic disease. So there are about 3,000 patients in this trial, randomized to atorvastatin 40 versus placebo. Average LDL in both arms was 124, and median follow-up was 2.5 years, but the study was terminated early because of a lower than expected event rate, defined as cardiovascular death, MI, stroke, TIA, or revascularization procedure. So there was a trend towards a lower cardiovascular event rate in the statin arm, but the result did not meet significance. So in summary, the patients with rheumatic disease have a higher risk of atherosclerotic disease. The cardiovascular risk is associated with higher disease activity and use of NSAIDs and glucocorticoids. For the time being, the general population risk estimators are still our best choice for risk estimation. And controlling the rheumatic disease, lifestyle modifications, and statins are the keys to disease prevention in our patients. All right, so that's all I have for today. I'll happy to take any questions from the audience. Thank you.
Any questions?
Yes. Hi, David. This is Dr. Wang in the Heart Institute. Very interesting presentation. My question to you is there good animal models to study the correlation of RA as well as the atherosclerosis or some other cardiac diseases? Because the reason I ask about it is from what I heard about you presenting this clinical trial or study the correlation, many of the inflammatory factors, of course, in the RA disease area is also involved, as you said, in the cardiovascular. So is there a good animal model system to allow us to study this together? I know some of the animal models for cardiovascular. How about the RA system to study together?
Yeah, so it's a good question. I'm not the most familiar with the animal models for this. I mostly did clinical research. In terms of animal models in RA in general, there definitely are decent animal models, I would say, for RA. There are like knockout mice that have a similar phenotype as RA, which are definitely used in basic science research in RA. I am not sure, I'm not aware of any studies using those animal models to look at atherosclerotic disease. I think most of the research has been using clinical administrative data. There's also imaging studies using like calcium scores like CT, the coronaries, carotid intimal media thickness by ultrasound. That's surrogates for atherosclerosis. And there's a good amount of research using those kind of markers to look at like preclinical atherosclerosis in our patients. But to answer your specific question, I'm not aware of any studies that have looked at animal models of like RA to investigate atherosclerotic disease in particular.
Okay, can I also ask another related maybe question? So maybe you are aware of it that the basic research or translational research, we also applied the induced pluripotent stem cell system, IPS system, to differentiate them into different cell types and try to model different cardiovascular diseases in vitro in a petri dish. Are you aware of any of those being applied to study in the RA area? Again, we probably can start the similar correlation of RA or atherosclerosis or other cardiac diseases. The IPS cell system for RA.
I'm not personally aware of studies using IPS systems in RA.
Okay.
Yeah, generally they use like knockout mice that have phenotypes with like synovitis that look like RA. It doesn't match perfectly like human RA, but some of them, definitely have features that are similar, and they're used in those settings.
Okay, great. Thank you.
You're welcome.
Hey, Jen, I'm available now. So thank you, Dr. Ying, for your talk. I was going through a dead zone of here on my cell, but I pulled over to a secure area. Again, thank you for your talk, first of all. And I think Dr. Ledford had a comment, and then we're going to go to Dr. Sukari. Go ahead, Dr. Ledford.
Sorry, I was. David, do you have any either evidence or just experience, or maybe even a gut feeling that um,
I think your mic might have cut out.
Dennis, I think your mic cut off. See if you can adjust location.
And he left his question in chat.
Oh, okay.
Yeah, see if you can see it, David.
If you'd
and then
like
we're
to
going
take
to
it from there.
Sure, let me pull that up.
I'm happy to read it for you if
Okay,
it's
yeah,
easier.
I see it now.
Okay.
So sirolimus, which inhibits T cell activation, reduces atherosclerosis or stent obstruction. Is there any evidence of continuing anti-lymphocyte therapies despite disease improvements such as mycophenolate, methotrexate, azathioprine, calcineurin inhibitors in patients with autoimmune disease?
I'm sorry. I guess I lost signal. Can you hear me now?
Yes, I can
Yeah,
hear you now.
yeah.
I'm just wondering.
David read your question. Yeah.
Okay, but many of the studies, like with TNF inhibitors, maintain methotrexate even as people improved. So I'm just wondering if you think there might be some advantage in maintaining low dose of these therapies when people with rheumatoid arthritis or lupus are actually better, because you might be suppressing cardiovascular complications.
Yeah, this is a good question. I'm not aware that this has been studied for these medications in particular. Um, uh, I mean, in general, we do tend to continue these diseases, so to continue these medications in patients that are well controlled in RA or lupus to kind of maintain that. Occasionally, we'll taper off the medications, but only if they've been very stable for a long time. As to whether there's some benefit cardiovascular from that standpoint, maybe, but I'm not aware of any data in that regard.
Thank you.
Dr. Sakari.
Hey,
Go ahead, Dr. Sakari.
can you hear me well?
Yeah.
Thank you, Dr. Ying. Thank you for the talk. So actually, I missed in and out because also of my connection. So maybe you already mentioned some of those things. So I'm aware they studied low-dose methotrexate for prevention of atherosclerotic diseases. A few years ago, that was published in New England Journal, and it wasn't as exciting as we hoped because theoretically it makes perfect sense. So they put those patients, they looked at their inflammatory markers, all the cardiovascular disease issues, lipid profile, but it didn't show the endpoint. I don't think it showed any benefits of having low-dose methotrexate. Having said that, I think those patients were not rheumatoid arthritis patients. They just, because of theory of maybe methotrexate will help patients with coronary artery disease with elevated inflammation markers, specifically CRP, they went with that rationale. I think they're studying to do another study maybe with a different patient population. I was also going to mention for the basic science thing, I know there is a lot going on in lupus accelerated atherosclerosis diseases. I don't know the details, what exactly they're studying and what did it show, but I know a few people that were looking into that because also they know from lupus population, they tend to have all these severe outcomes. So they design models of mouse with coronary disease, and they study the lupus events and how they can control it. But it'll be nice to know. Yeah, I'd be curious. I don't know much about those yet.
Okay, yeah, I'm not aware of those personally. But yeah, that'd be nice.
Very good. Thank you, Dr. Sakari. Very good stuff. I believe that's all we have for questions, but we're going to have Dr. Gupta. We wanted to have some time for Dr. Gupta to highlight the final grand rounds of the year, which will be held May 29th. And Shanu, are you on?
I am. Thank you, Dr.
I'm
Lezama,
going to
for
give the
giving.
floor to you. Yes, take it away.
Thank you. Thanks so much. I think Dr. Perry is also on. She's really leading the charge for the iMerge Grand Rounds. In the chat box, you'll see the flyer for the Grand Rounds that we're planning for, and the link that Ashley has placed in there as well for entries, for submission entries. Ashley, you want to give us a sense of what we're hoping for?
Sure. Hey, everyone. Thanks for letting us talk about the exciting grand rounds for next month. So we are holding a research competition for all of our medical students, residents, and fellows to submit to. Any research within the Department of Internal Medicine is open. We're looking for any clinical research, quality improvement research, medical education research, really anything that the trainees and medical students are working on is something that we would consider for review. Unfortunately, we're not able to accept case reports, but any other type of research is welcome. We are even accepting research that has already been published. So if you guys have anything at all that you want to share with the department, please do encourage the trainees and students to submit that. We will be selecting 3 winners, one from each research category to present on the research day on May 29th. The flyer is in the chat. We are hoping that all of the submissions will be in by April 28th so that we have time for our faculty judges to review those, and the link is there as well. And then we're also looking for judges to review the abstracts. So if you are a faculty member who is interested in judging these abstracts of our trainees, even if you have a trainee who will be submitting something, you're still eligible to judge. So please reach out to me. I'll put my email address in the chat, and we will make sure that you don't receive the submission that you submitted to review. So yes, please encourage people to apply, and hopefully you guys will be able to come next month and see all of the incredible work that our trainees and medical students have been engaged in this year.
And to clarify, this is open for projects with medical students, with residents, with fellows. We really want to be able to celebrate all of the really amazing scholarly work that is already happening within the department, and also to give visibility to those that have been working hard.
Thank you very much, Dr. Gupta and Dr. Perry. This is very exciting, and this will be our last grand rounds of the year, as it was last year. So ending with a high note with a lot of our trainee involvement. As stated, anywhere from medical students, residents, fellows, that is what we're looking for. We need judges as well, as Dr. Gupta and Dr. Perry stated. So this is what Dr. Mosley talks about, academic citizenship. So hopefully folks will step up so that we have a fantastic grand rounds. Okay, I'd like to thank again Dr. Ying for great grand rounds today. And thank you all. I hope you have a wonderful day. Hope you get to enjoy some of this gorgeous day that we have outside. So take care, and we'll see you all next week. Thank you.
Hey, Dr. Shutter, do you have a question that you'd like to ask?
We had one last
Hi,
question.
yes, just Paul Shutter, nurse practitioner with general cardiology. Is it possible that with the suggestion, rather, with the rheumatology department to maybe also give another grand rounds on not only just the atherosclerotic disease risk, but even like the pericardial risk, as well as looking at like rheumatoid arthritis, lupus, Sjogren's, et cetera, and the effects of pulmonary hypertension?
I think it's a great idea. I think this is a great grounds with Dr. Sakari and Dr. Matar to talk about doing something together, get you involved as well, since you have the initiative here, and I love the idea. I'd love to see, and we've done, we had a rheumatology and I think it was rheumatology and nephrology, yes, combined grand rounds, which was fantastic a couple of years ago. And so, yes, I think, part of what Dr. Mosley and I have talked about is, and talked about in the education retreat by the faculty leaders of education, was collaborations, division collaboration. So I think this is a great idea. So yeah, my excitement and enthusiasm behind it. Thanks for this. And Dr. Sakari, who's on this call, I think, Lufti, please take this and work with the cardiology division. I think this is a great idea. All right, good. I like it. This is